This is great. Boy, what Mills always looked good in those pictures, but that was very, very kind of you. And then by juxtaposition, he looks even better, next to the. There's much to talk about later, Jorge. And by the way, I've visited behind us is Dave and the crew from Portal. Beaming from Australia, back to dozens of countries around the world who are watching right now and streaming live. So if you're in your underwear or your PJs, looking at your tablet, buckle up. There's more to come, and it's great. And I think you all got the message outside of here and inside. If you have questions, we have kind of the command center right here, and you can just hashtag and send your message through whatever means you want, Twitter, Facebook, etc., etc., etc. And that's not Tinder if you're dating. So, ladies and gentlemen, our third contestant is another DFCon veteran, and that's Grant Skrepnik. He used to be at the University of Arizona, but thought better of it and now has this Taj Mahal to pharmacoeconomy and pharmacoeconomics at the Oklahoma Health Science Center. Grant came in last year with a full head of steam, and I mean, really, it was unbelievable. It was like this hyperthyroid performance, looking at an astonishing amount of data. He's back for more, but now I'm concerned because now he's talking about an emergency, not just diabetic foot in general. So the 2 million foot long emergency diabetic, the 2 million foot long emergency diabetic foot emergency department admissions in the United States. Please help me welcome my good friend, and Joe's good friend too, our salsa amigo, Grant Skrepnik.
Thank you. A number of things have often been said about economics, and foremost, it is often viewed as a dismal science. One of the key principles of economics, however, is that it does not lie. Economics is often misinterpreted or manipulated, but it does not lie. And one of the key things, these numbers, these outcomes that are associated with the diabetic foot in terms of both scope and severity are critical. They're absolutely critical to drive sound policy. And with that, I actually would like to talk not only about emergency department visits in the United States, but also inpatient care and remarkable disparities that we have really discovered over the last several years in our large database and large policy-based research investigations. I'm very much preaching to the choir when I say that the diabetic foot is all too common and all too costly. Not only costly to patients in terms of their own health outcomes, but also attributed to 1/3 or greater of all diabetes treatment costs. With that, our overall, and there are several studies that are represented in this presentation, it was generally to assess the major complications and economic impact of diabetic foot ulcers within both hospital inpatient care from 2001 to 2010, as well as emergency departments from 2006 to 2010. The study design, we used nationally representative inpatient and emergency department data. As we will see, the scope is quite remarkable. Essentially, we are looking at all-cause diagnoses of diabetic foot ulcers among adults. Several variables, and again, some of these numbers are going to be presented in greater detail on Saturday, especially those relating to specifically costs. But our analysis looked at 4 different types of outcomes. Major complications associated with the diabetic foot: death, sepsis, surgical complications, amputation, also within that, disposition from the emergency department, length of stay, and charges. And the key is that we've conducted some fairly elaborate econometric analyses to control for a number of various factors that can potentially explain these outcomes as well. Focusing on inpatient visits. 388.4 million admissions in the U.S. across this time span, about 17% relating to diabetes, and within that, 3.8% of diabetes cases involved in some fashion the diabetic foot. As we see on these two graphs, on the left-hand side we see that the number is indeed increasing for the number of cases of inpatient visits associated with the diabetic foot, but as a percentage of diabetes cases fairly flat. And what are some of the takeaways that you can actually make from this? Might be these are not the most ideal places to either render or receive care. In some cases, at least, the diabetic foot, the percentages have not been going up, but they also have not been going down. And as a policy analyst, one of the key takeaways that I might take from this is that we need a much better coordinated care system associated with diabetic foot and diabetes in general. Severe aggregate outcomes, excluding amputation, about 19%, including amputation, almost a third. Inpatient mortality, 2.3%. Just in terms of a lot of the other work that I do, let's say in the cancer area, this resembles a number of cancers. 2 to 5% is not uncommon to see for an inpatient case of mortality. Surgical complications, 11%. Sepsis, 8%. And as you can see, in terms of the percent of diabetic foot ulcer inpatient cases associated with these types of outcomes, fairly flat throughout that decade. The cost is enormous. These are the charges, $250 billion for diabetes in inpatient setting. And I always like to put this in perspective. So across the 10-year time horizon, that's $2.5 trillion. $250 billion in 1 year is getting into the cost of Medicare in this country. And that is absolutely remarkable. Diabetic foot ulcers, so that's $11.6 billion per case, right around $50,000. When there's a revascularization that occurs, this approaches $100,000 per case. As you can see, and these are, of course, these are inflation-adjusted figures, and these not only are inflation-adjusted, but this is inflation-adjusted against all other medical services. So it's not just the consumer price index here. All other medical services are taken into account. The bill is going up. The mean inpatient charges are also going up, as we can see. In terms of length of stay, diabetic foot ulcers, a little over a week. Revascularizations, almost 2 weeks. The length of stay is going down. So length of stay is going down. Charges are going up. Again, this is indicative that there's an increased intensity of care that is being rendered. Apologies, I'm trying to advance here as well. Doesn't seem to be doing it. Oops. I'll go back. In terms of just some general descriptives before we get to the multivariable results. Average age, right around 65 years. Generally male for diabetic foot ulcers. Again, we've already talked about length of stay, charges. One of the more disturbing findings that we have found are disparities that exist based on race, region, and payer. And these are the multivariable results. So what these are indicating, and this is broken down by decade, the first half of the decade, the second half of the decade. This is controlling for all other factors. These are just the individual correlations, if you will, of these factors associated with amputation and inpatient death, for example. Rural residents versus urban for 2006 to 2010 indicates a 32% higher likelihood, controlling for all other factors, 32% higher likelihood of amputation, 16% higher likelihood of death. And that controls for age, it controls for comorbid conditions, it controls for income, payer, all of these other factors as well. African American, 28% higher likelihood of amputation. Hispanic, 20% higher likelihood. Asian Pacific Islander, 17% higher likelihood of amputation. Something else that's also highlighted on the bottom, year. Well, year is indicating that over the entire decade that there has been really no impact on, no decrease in the number or odds of amputation, but in the latter half of the decade, about a 9% reduction in inpatient death. Again, the overall results of what these are telling me is that we need a much better coordinated care, culturally sensitive care that is actually targeted to our most vulnerable populations. Now, focusing on emergency departments, and when I mentioned that there are a lot of numbers here, 625 million emergency department visits were evaluated for this particular study. 8.7% involved any diagnosis of diabetes, just under 2% diabetic foot ulcers. Now, of these individuals that went into the emergency department, ultimately 81% were admitted. 61% of all inpatient cases emanated from the emergency department. As you can see, the numbers are continuing to increase in terms of overall cases and the national bill. The national bill, again, we'll talk more about on Saturday, $8.6 billion per year. The number seems fairly low for the per case, the annual, or the average per case cost, $2,000. But as you can see, it depends on what's happening. With obviously an amputation, it's going to approach $100,000. Mortality, admission, and on the very bottom will be your treat and release or transfer cases. But again, those data are highly skewed. Most cases are admitted. 81.2%. Almost a quarter had severe aggregate outcomes, 10.5% amputations, surgical complications, sepsis, and death, as you can see, all fairly high. Again, very much resembling the inpatient analysis in terms of descriptives. One of the key things, and here we were not able to evaluate the association of race simply because the data did not collect those important demographics. But what we have seen is that in the latter half of the decade, very much resembling our inpatient analysis, again, rural residents, individuals that will go into the emergency department, rural residents, 24% higher likelihood of amputation, Medicaid, 34% higher, lowest income, 17% higher. Now, when you begin to factor all of these in, if someone that lives rurally is Medicaid and lower income, you have an absolute train wreck. Absolute train wreck. Highlighted on the bottom here, year, there has been no decrease in the odds of amputation or inpatient death in cases emanating from the emergency department. We've also broken down, and this is I think a fairly nice graphic to explain our results. We did break down these in terms of major versus minor amputation. I am not from the camp that thinks a minor amputation is a good thing. You know, I have worked clinically, and I do appreciate that if you save the patient with a minor amputation, it is good. But it's also a failure of preventative care in the first place. So we broke down major versus minor amputations as well as death. And as you can see, these are essentially forest plots with the red line indicating no significant difference. But we do find significant increases with rural residents for major amputations and minor amputations as well as death. These are approaching, major amputation approaching 60% higher, really remarkable. For Medicaid, major and minor amputations and lowest income quartile, we see major amputation as a factor, about 40% higher. So in conclusion, a lot of results coming out here. Within inpatient and emergency department settings, we've seen that diabetic foot ulcers have remained relatively constant over time as a percentage of diabetes. They're involved in a substantial number of severe outcomes ranging from about 1/4 to 1/3 that are involving death, sepsis, amputation, surgical complications. These cases frequently originate from the emergency department. Again, I would say that in some ways this is reflective of a poorly coordinated care system, that there would be a reliance upon that. 61% of all inpatient DFU cases do emanate from the ED, and they are present with significant and substantial racial and rural disparities. Higher odds of amputations based upon race, and also on rural settings associated with cases presenting to the emergency department. So quite a bit to think about with this. Thank you for your time and attention.
Your name was Grant Grim Reaper, was it? That was very, very compelling data, Grant.